Welcome. I'm Dr. Christine Palmay from Midtown Toronto, and I am joined by my colleague, Dr. Michelle Jacobson, who is an OBGYN, and we're here to talk about iron deficiency.
Thank you so much, Christine. I'm very excited to be here with you talking about this subject.
Absolutely. We're going to be focusing on women. Iron deficiency is common, amongst many populations, but for the purposes of this, we're talking about women, iron deficiency, um, and how common it is. So, Michelle, how common is it?
Iron deficiency is extremely common, and iron deficiency anemia is
Mm.
also extremely common. But in Canada, there's over 2 million people who are anemic, and it is much more prevalent in women than in men, mostly because women spend a lot of their lives losing blood on a monthly basis. And sometimes that blood loss can be significant and can lead to more anemia over time. So once
Mm.
women get into menopause, they stop having periods, the numbers tend to stable out a little bit. But for most of their reproductive lives, women are about twice as likely to be anemic from iron deficiency as men are.
Absolutely. Perhaps you add vegan diets, vegetarian diets, and I think the reality is that iron deficiency and iron deficiency anemia, which we're actually trying to prevent, really affects patients. What are some signs and symptoms, Michelle, when a patient comes to you, other than heavy menstrual bleeding, that make you think, geez, I have to do a bit of a workup?
Well, the menstrual bleeding is more of a risk factor. So, certainly for women who are at high risk because they have heavy menstrual bleeding, or women who are pregnant, or women who are lactating, or women whose pregnancies are close together, these are all women that we are going to worry about having iron deficiency or iron deficiency anemia. But the symptoms are actually very vague. They're a little bit sneaky because a lot of the symptoms of iron deficiency overlap with many other symptoms of diseases and states that we're very used to. So, women with iron deficiency can have a low mood, they can have a low exercise tolerance, they can have fatigue, they can have
Mhm.
leg cramps, their hair can fall out, their skin can feel dry. It's very, very common to have the symptoms of iron deficiency anemia overlap with those of the diagnostic criteria for depression. And so, if we don't have iron deficiency and iron deficiency anemia on our differential diagnosis, we may miss something that is so easily treated while we're chasing other less common diagnoses.
So let's talk about workup. What are you ordering? What are you not ordering? And how are you interpreting the results?
So, great question. And I think that we back up even one step and say, in whom are we ordering these
Good,
tests?
good point.
Right? So, should we be checking every single human being that we see in our practice for iron deficiency anemia? Not if they are asymptomatic, unless they are part of special populations. And the
Mm.
special populations that might come across the gynecologist's office or that are particular in women's health are women who have heavy menstrual bleeding, women preoperatively, especially who are going for major gynecologic surgery, women who are pregnant or women who are lactating, and women who have conditions that also affect men, but that predispose them to iron deficiency. So that's going to be things like absorption disorders like celiac, inflammatory disorders like IBD, and of course, oncologic patients who might be losing blood that we don't know about or having trouble with their own bone marrow. We also think about it in special populations like people with kidney disease, in whom, or with cardiac disease, in whom we are actually targeting different levels for iron replacement and for hemoglobin than the general population. So, at the end, we end up probably testing a lot of people because people fall into all sorts of buckets, and these buckets are not mutually exclusive. But it really is important that we think about these populations, even if their symptoms are not obvious. And then when it comes to how we would test for iron deficiency and iron deficiency anemia, usually we would start with sort of the lowest hanging fruit, which is going to be a CBC or a complete blood count, which is going to give us a hemoglobin level, but it's also going to give us an MCV, which is something that we can look at And it may also give us clues if we're deciding to be detectives when it comes to iron deficiency anemia with regards to the MCV, the reticulocyte count, those kinds of measurements, which can give us some direction as to how the body is responding and the etiology of these problems. Of course, we also have to order a ferritin, and a ferritin is the best indicator of our stores of iron. So, in somebody who doesn't have any processes that are impairing their ability to store, transfer, and utilize iron, a ferritin is a good enough test to determine if they are iron deficient at minimum or in combination with a low hemoglobin, anemic and iron deficient. And then we want to get into some special testing for certain populations where we think perhaps there might be a hemoglobinopathy, depending on what part of the world their ethnic background is from. Testing something like a hemoglobin electrophoresis can also help you to interpret when that MCV is low to determine if it's low because of only iron deficiency, because of a hemoglobinopathy, or a combination of the both, which is actually very, very common. So almost always, even when anemia is present, iron deficiency does play some role. And I know you're going to ask me, what about those things that we learned in medical school, the iron studies, the things that you never want to have to interpret? You put it right up there with the hepatitis interpretation, right? When it comes to those more advanced studies, you can order iron binding studies, total iron binding capacity. These are going to be very helpful in further understanding where the problem is. So, if the problem is with iron storage or with iron transfer or with iron utilization, and in periods of inflammation, the total iron binding capacity is very, very helpful. But I would start simple because my whole life has to be simple. And I would order a CBC, a ferritin, plus or minus a hemoglobin electrophoresis as my first set of tests.
Absolutely. And I think we'll share on resources the sort of thresholds for official determinants of iron deficiency. But the reality is, too, you have to look at your patient. Let's
100%.
segue into treatment options. What are your first line options? What do we have available to us? And some exciting new data as well.
Yeah. So, assuming we've determined that our problem here is with iron storage, that our ferritin is low and we need to refill those iron stores, we want to do iron replacement. And what you can use depends, of course, on a number of things, what you can afford, what you can tolerate, your medical history, and your current status. So, pregnant women in the first trimester are going to use more oral iron replacement. Whereas later and closer to delivery, they may focus more on an IV iron replacement due to time and due to failed absorption over time. But if we are taking sort of all comers, we're always going to start with oral iron replacement. And for the most part, that will start with iron salts, which are usually quite affordable. The question is of tolerance in many women and men as well, where oral iron salts can cause GI side effects like black tarry stools, nausea, reflux, constipation. And this is what makes them difficult to tolerate. But across the board, in terms of the different oral iron salts that are available, one is not necessarily better than the other. It is the one that you are able to tolerate the most and be the most compliant with that is the most effective. And the kind of rules of thumb or special rules about oral iron absorption is for the most part, you want to take it with something acidic, barring some of the nutrients that actually come with an acid attached to them, because the acid helps the absorption of the iron in the stomach, which is where most iron salts are absorbed. You want to make sure you don't take it with any substances that are going to impede its absorption. This is particularly true for calcium containing products. And ideally, you want to take it mostly on an empty stomach with that acidic juice or a vitamin C capsule, something like that. There's lots of different iron salts that are available. Some are considered to be gentler or easier to digest than others, but in general, this is very individualized, and the amount of elemental iron does not change much from one oral iron salt to another because we change the way we take our iron salts based on how much elemental iron we need to take. The other caveat here is there's this, I call it like the sick joke of iron replacement, where if you take too much iron, you can increase something called a hepcidin level, which stops you from absorbing iron. So there are certain irons that we want to be careful and actually space out in terms of taking them every other day rather than daily, because we will actually get better absorption over time.
I found that switching to that every other day dosing actually ends up with improved efficacy. Um, we are nearing time, so I just wanted to take a moment to talk about this pivotal trial that was looking at comparative studies of iron over-the-counter options available. We can't go through possibly everything in a short course, but I think this is a really important study from a practical purposes.
Yeah, absolutely. And, I started talking about iron salts and I didn't get to talking about the other iron replacements. So things like the polysaccharide irons, which are very popular as well, the heme irons, which overall, again, all of these do tend to lead to similar iron replacements. They're just different in terms of how they're tolerated and what the composition of the tablet is, which may have implications for people who are vegetarian or not. But the study that you bring up is looking at the differences in the efficacy of ferrous fumarate, ferrous ascorbate, and polysaccharides for replacing iron in iron deficient adults. And I mentioned that there are some special formulations that have the acidic component included. That's going to be the ferrous ascorbate. So this is iron that actually has vitamin C included in it already, so they don't need to be taken separately, and probably for many reasons, but that one being important. The ferrous ascorbate did have the highest increase in hemoglobin from baseline at 17.14 grams per liter, followed by the ferrous fumarate and then the polysaccharide iron in a significant way. So when we look at the pudding, as I like to call it, the proof is in the pudding, we're looking at overall the increase in hemoglobin level. So the ferrous fumarate, the polysaccharide iron, and the ferrous ascorbate compared to each other showed that the ferrous ascorbate resulted in the highest increase in ferritin and in hemoglobin overall, and with very, very few adverse events, fairly well tolerated, and likely best absorbed because of that acidic component. They're all fairly similar when it comes to replacement, but they are all tolerated slightly differently and cost slightly different amounts.
I think, take home messages for our viewers. Number one, don't underappreciate the ramifications of iron deficiency and, take the reference values with a grain of salt and actually speak to your patient. Number two, we have multiple oral formulations, all differ in, dosing, absorption, tolerability, but I like to put the emphasis on tolerability and, asking your patients how they're doing because I find that most often than not, patients have stopped their iron. They won't tell you because they feel guilty or forget or whatnot. And there's nothing more expensive than a prescription that was bought and not used. And number three, just check in regularly. If one thing doesn't work, you can switch to another options. And I think these smarter options that we have, including ascorbic acid in the pill, we know that, the more pill burden people have, the less likely they're going to take their medications, and this makes things a little bit simpler.
And if
Um,
it's simple, they're more likely to be
yeah,
compliant. And what's nice
absolutely.
now also that I really appreciate as an obstetrician is we're getting more and more data in pregnancy, which is so rare when it comes to medications in pregnancy. So, for example, the EBMfer, which is the one that contains the ascorbic acid, has data and approval in pregnancy. Our IV irons have approval in pregnancy. So we are opening up a world of options for women at all stages in their reproductive lives. I'm very appreciative for that.
Absolutely. Thank you so much, Michelle, for spending your time with us. Thank you to our readership, and we'll be including some resources too for your reference.
Thank you.